talk to you about the efficiency of the different kind of heart rates as the rhythms propagate through the heart. So the normal pacemaker of the heart is generated always from the SA node. It comes down to the AV node through the bundle of His, through the bundle branches and the Purkinje fibers. So I know I've said that probably 30 times already in the presentation, because you have to know the normal conduction system of the heart. When I teach a basic dysrhythmia course, I want you to try to understand, and I just give you some general numbers that really have no scientific background or evidence behind them, but I just want you to have an understanding of how effective the heart is. So normally, when the heart is firing from the SA node, it produces a P, a QRS, and a T wave, and it fires at a normal rate of 60 to 100 beats per minute. So if for any reason the SA node fails to work as the pacemaker of the heart, perhaps the patient had an infarction, they have hypoxia, they've had any type of myocardial injury that you lost perfusion to the SA node, it will go down to the next pacemaker in the heart, which is the junctional tissue. So it's the tissue around the AV node. So how do you know when you have a junctional rhythm? Okay, so you have an absence of a P wave, a QRS and a T, or an inverted P wave, a QRS and a T. It can also be inverted and after the QRS. So just the different morphologies of the waveform. But as you drop down in the heart, now here's an example of non-scientific information. Let's say the heart functions at 100% from the SA node, because the heart is intended to function and work and meet the basic metabolic demands from the SA node. So now we're down in the junction, so we lose the ability for the atria to fill appropriately, to perfuse down and fill the ventricle. So we lose the atrial kick that you would generate with the sinus rhythm, but now we're down in the junction. So normal junctional rhythms fire at a rate of 40 to 60 beats per minute. It can speed up, however, that is the normal pacemaker function of the junctional tissue. So although people can live in a junctional rhythm, let's say, for example, that meets 75% of the basic metabolic needs of the body. So now, let's say we have a patient that had a quite large infarction that has taken out the SA node and the AV node, and now the only perfusion we have are down in the ventricles. How do we know when we have a ventricular rhythm? We have absolutely no P waves because we have no electrical activity in the atria. However, we have a wide QRS and a T. And we know that because the QRS points in one direction, the T in the other. Now I'm drawing on an angle, so it's QRS and T, and it would be a repetitive rhythm like that. The normal rate of the ventricle is 20 to 40 beats per minute. So as you can imagine, this is not a rhythm that supports life. So that's why we try to break ventricular rhythms when they're slow, because they're functioning at their normal rate of 20 to 40. So sinus is 60 to 100, functions fully efficiently at 100%. The junction a little slower at 40 to 60, about 75%. And if you can imagine, down in the ventricle, it really cannot support life. So let's say if we had to give it an imaginary number to it, it would be about 25%. That's why when we talk about the function of the heart, we always want to force it up to the highest pacemaker of the heart, that being the sinus node, and the place we don't want that patient to be is in a ventricular rhythm.